The healthcare industry is undergoing a massive economic realignment. Over the next decade, approximately $1 trillion in annual spending will migrate away from traditional administrative overhead and brick-and-mortar facilities, moving directly toward predictive, virtual-first, and AI-enabled care models. Driven by early optimism, executive boards are rapidly expanding their digital technology budgets. In 2024, these budgets accounted for an average of 8% of organizational revenue. For 2025, that allocation is rising to 14%. 73% of healthcare leaders report positive financial returns on generative AI investments within their first year. But long-term data reveals a contradiction. Up to 95% of these AI pilots fail to reach full enterprise scale. This high failure rate stems from a specific professional misconception. Executive boards are evaluating medical artificial intelligence as if it were a legacy electronic health record rollout. They treat the technology as static, depreciable IT infrastructure that can be installed and forgotten. By relying on these outdated metrics, organizations misprice the actual risk. They attempt to measure algorithmic impact through immediate cost reduction, rather than tracking its true value in building operational resilience and securing long-term market positioning against fierce competitors. Medical artificial intelligence functions as a highly variable operational expenditure. It serves as a primary weapon in the escalating financial war with insurance payers, introducing liability vectors that require entirely new C-suite governance to survive. Historically, hospital IT systems were built on massive upfront capital expenditures, known as CapEx. Installing an electronic health record meant buying perpetual software licenses, building on-premise server farms, and relying on favorable tax depreciation schedules over many years. This animated diagram illustrates the structural inversion occurring today. On the left, legacy CapEx is a solid, static block of investment. On the right, the AI ecosystem relies on cloud computing, software as a service models, and token-based application programming interfaces, or APIs. An API is a set of rules that lets different software programs communicate. This architecture shifts the financial burden to operational expenditures, or OpEx, which hit the profit and loss statement immediately as recurring costs. Because these models charge based on the volume of text they process, measured in tokens, OpEx introduces extreme P&L vulnerability. For a mid-sized health system, the annual pass-through costs of running a large language model can swing from a highly optimized $115,000 to over $4.6 million, depending entirely on usage controls. The initial licensing fee that an executive signs off on is often just a fraction of the total cost of ownership. It is the visible tip of a hidden financial iceberg. That visible tip represents the baseline software and initial vendor licensing. Depending on the clinical complexity, this upfront cost typically ranges between $50,000 and $300,000. The first major underwater cost is data curation and interoperability. Preparing siloed historical records to communicate seamlessly across systems using modern FHIR data standards can easily consume 15 to 30% of the total implementation budget. FHIR is the global standard for exchanging healthcare information electronically. Below that lies the relentless cost of human capital. Hospitals must hire specialized machine learning operations engineers, commanding salaries between $100,000 and $200,000, and clinical AI translators to bridge the gap between code and care. At the very bottom is the perpetual cost of continuous algorithmic validation. Clinical practice guidelines evolve, causing models to degrade in accuracy, known as data drift. Retraining algorithms to combat drift consumes up to 45% of lifecycle costs. Without stringent governance over token usage and vendor contracts, these hidden operational mechanics will silently erode a hospital's operating margins. What begins as a highly promising pilot will rapidly devolve into a recurring financial liability. To justify these massive new OpEx budgets, health systems are actively targeting their most critical operational vulnerability, the clinician burnout epidemic. The financial devastation of burnout is severe. When an exhausted physician leaves a practice, the institution incurs massive penalties in lost productivity and recruitment, costing between $800,000 and $1.3 million per departing doctor. In response, the deployment of ambient AI clinical scribes has become a universal strategic priority. These tools use natural language processing to passively listen to patient visits and write the medical notes automatically. Currently, 100% of surveyed health systems report active piloting or adoption of this specific technology. This dual-pane timeline visualizes the immediate clinical impact. On the top, a traditional clinician's day is consumed by long, solid blocks of manual documentation extending late into the evening. On the bottom, the AI ambient timeline compresses those documentation blocks. This yields an 8.5% absolute reduction in daily documentation time and eliminates the after-hours administrative work, colloquially known as pajama time.
The true financial model behind this time savings is capacity expansion. The recovered operational time is systematically reinvested by the health system to schedule additional acute or urgent add-on patients into the daily schedule. The return on investment for administrative AI derives from clinical capacity expansion. By generating new revenue without increasing the hospital's physical footprint or staffing levels, these tools provide a direct solution to the rising demand for care. While administrative tools capture quick wins, the most lucrative and heavily contested theater for medical AI resides in revenue cycle management, or RCM. This is the financial process facilities use to track patient care episodes from registration and appointment scheduling to the final payment of a balance. The baseline financial hemorrhage in this sector is staggering. Due to highly complex billing rules and prior authorization mandates, 22% of healthcare organizations lose at least $500,000 annually purely to claim denials. In response, hospitals are launching an aggressive offensive strategy. Providers are utilizing explainable AI and agentic coding to perfectly capture patient comorbidities, ensuring documentation perfectly matches the intensity of care. This approach has allowed organizations to reduce their accounts receivable days by 30%. Insurance payers are countering with their own sophisticated AI platforms. They use these systems to heavily scrutinize incoming claims and automate the denial of prior authorizations, actively searching for patterns they perceive as algorithmic upcoding by the providers. This conflict is now highly visible in public financial disclosures. Major insurance executives are explicitly blaming provider-side algorithms for inflating in-year claim amounts, actively citing aggressive coding tactics as a threat to their margins. This algorithmic warfare alters the balance of financial power. To mitigate the endless cycle of denials, forward-thinking entities are pushing for shared truth data models. These models utilize standardized FHIR frameworks to align coding rules and reach a consensus before a claim is ever submitted. Future contract negotiations between payers and providers will no longer rely on localized market relationships or historical prestige. They will be entirely dictated by algorithmic evidence and exact data leverage. Attempting to manage the revenue cycle without sophisticated artificial intelligence means fighting a modern financial war completely unarmed. Beyond internal financial friction, health systems face an impending external shock. The regulatory landscape is rapidly shifting into a chaotic, fragmented matrix of federal mandates and strict state-level legislation. The U.S. Food and Drug Administration is actively cracking down on clinical decision support software. If an algorithm goes beyond basic reference information to make patient-specific diagnostic suggestions, it is now legally classified as software as a medical device. Navigating this compliance pathway immediately adds hundreds of thousands of dollars to the cost of procurement. Concurrently, the Department of Health and Human Services has finalized the HTI-1 rule. By 2026, this regulation mandates first-of-its-kind algorithmic transparency and stringent intervention risk management practices for any predictive model integrated into a certified health IT system. Simultaneously, the mechanics of medical malpractice are evolving. Plaintiffs' attorneys are aggressively targeting the opaque, black box nature of AI decision-making. Internationally, the European Union's AI Act has set a stark precedent by formally classifying algorithms as products, effectively shifting the legal burden of proof away from the clinician and entirely onto the software creators. Because an algorithmic misdiagnosis or a biased training dataset can trigger uncapped HIPAA fines and devastating malpractice exposure, healthcare AI can no longer exist in a regulatory gray area. HIPAA is the federal law that strictly protects sensitive patient health information from being disclosed without consent.
To manage this complex matrix of operational, financial, and legal risk, hospitals are mandating a specific organizational response, the elevation of the Chief AI Officer, or CAIO. This organizational chart shows how leadership must restructure. Robust governance cannot exist in an isolated IT department. The Chief AI Officer rested directly in the C-suite, operating in parallel with the Chief Information Officer and Chief Medical Officer to strategically architect enterprise-wide deployment. The CAIO relies on highly structured, cross-functional governance committees. These panels must integrate practicing clinicians, biomedical ethicists, and cybersecurity experts to continuously audit live algorithms for data drift and systemic bias. The data on this is unequivocal. Organizations where the Chief Executive Officer maintains direct, active oversight of these specific governance structures report the highest correlation with bottom-line financial impact. The organizations capturing this trillion-dollar economic shift manage artificial intelligence as a compounding enterprise asset. They have replaced traditional IT procurement with the relentless, cross-functional strategic stewardship required to navigate the future of medicine.